This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm TG LaFredo, and this week we are in the KRMC Sleep Lab. My guest is Mark Hopkins. He's the clinical supervisor. Hey, Mark, welcome.
Thank you. It's nice to be here.
Yeah, it's nice to be here. I've never been inside the sleep lab before. It's very interesting. We're actually we're recording inside of one of the rooms where you have patients come in and try to get a night of sleep, right?
That's correct.
And so I'm feeling very relaxed. In fact, my eyes are getting a little bit heavy.
You're getting sleepy, very, very sleepy.
Do you do hypnosis here as well?
I am certified in hypnosis, but I really don't perform hypnosis here at the sleep lab, except for relaxation therapy.
Yeah, you really do. See, I think I'm joking about this stuff, but there's probably a lot that's going on, and so I'm glad we're here. We'll figure out what.
Absolutely, yes.
What do you guys do here? Tell me about the 101 of the sleep lab.
Okay. Well, first of all, we diagnose and treat individuals for various sleep disorders, such as obstructive sleep apnea, insomnia, narcolepsy, restless leg syndrome. The list goes on and on.
And when I walked in, you said, there are 85 different sleep disorders.
That's correct.
I can't believe there are that many.
There's quite a few, and that's the National Sleep Association has determined that there are, in fact, 85 different sleep disorders, too numerous to mention.
Right.
Anything, there's parasomnias, things that go bump in the night, sleepwalking, sleep talking, body rocking. It's people get on their hands and knees and start banging their head against the wall.
Oh my gosh!
Very unusual behaviors, REM behavior disorders.
Now, we're starting with the outliers, I realize, but with that sort of stuff, do they have a memory of it in the morning? So if I've been rocking and bang, I wake up with a bruise, or do I remember that happening?
No, not normally.
Yeah.
No.
Wow.
Yeah. It's very unusual.
So what's that all about?
That's a good question. We don't have enough time for that right here.
Okay. All right, fair enough. We should probably focus more toward the middle of the bell curve.
Okay.
And the stuff you see all the time. And I know one of those is sleep apnea. This is a problem that a lot of Americans are facing.
Yes, sleep apnea is probably the most predominant sleep disorders outside of insomnia. What we find that the insomnia patients actually have sleep apnea. So, and then the way we treat that, we have a certain window of time when the patient gets here.
I'm sorry, I'm going to interrupt.
Okay.
Let's define sleep apnea just to begin with, right?
Okay, sure. It's sleep apnea is the cessation of breathing while you're sleeping for at least 10 seconds.
Okay.
I've seen people quit breathing up to 2 minutes.
Oh my God.
It's quite frightening. So this can go on hundreds of times during the night. So it's very concerning because it's linked to a lot of disease processes, including heart failure, stroke, diabetes. It just increases the chance of Alzheimer's. The list goes on and on. It gets all your blood sugars off balance, and then your hormones get off kilter.
And the root of it is you're just not getting enough oxygen to feed your processes.
That is correct. When you quit breathing, your oxygen levels tend to just gradually drop. And you don't get the right amount of sleep in the different sleep stages. And that's really disruptive to getting a good night's rest.
So same story, though. You wouldn't necessarily know that you're quitting breathing. You just know that you're not getting as much rest, or how does it work?
Usually what happens, and you go on, and in the daytime you feel fatigue, lack of energy, your thinking isn't real clear. You do not perform as efficiently as people with a good night's sleep.
Yeah.
And then as far as learning that you have sleep apnea without going into a sleep lab, it's usually from a bed partner.
Yeah.
Hey, you snore and you also quit breathing. So it's usually the spouse that's really concerned. And then you have a few pokes in the ribs from wake up, so it's a little concerning for both
make
parties.
Sure that you're still alive here.
That's right.
Yeah, boy. Is this aberrant behavior to begin with, or does it happen to all of us to some normal extent?
Right. It is normal for everyone to have a little bit of sleep apnea. I mean, it's quite normal.
Okay.
And we use what we call an AHI. That's what the doctors really look at on the reports. And what that means is apnea. And H, it stands for hypopnea. It's a little partial airflow, but it's still a blockage. And index is how many times you quit breathing. So we look at the whole study. It'd be about 932nd pages if you were putting it into a form of a book.
Okay.
And we tag every one of those events where you quit breathing. That comes up with this AHI. And that's what the doctors really look at. So anything less than an AHI of 5 is quite normal. And then, anything from 10 to 20, you're looking at mild to moderate. 20 to 30 and on up, you're looking at severe. So that's not normal.
What are the correlates? I think obesity is one. Is that right?
That is correct. Uh-huh.
And are there other indicators that you look for?
Well, the neck size. A lot of patients that come in have a really short neck and thick neck.
Yeah.
So when they lay in bed, they put all that gravitational pull on the back of their throat, especially in supine or on their back. Tends to be worse. Weight, and you mentioned it, is a contributor because it puts weight on the diaphragm and it causes restriction of airflow. Yeah. So if you do have apnea, it causes it sometimes to be a little longer and a little worse and more frequent. However, weight's not always a factor.
Okay.
I've seen some real thin, skinny people come in here with sleep apnea. A lot of times it has to do with the structure inside the throat, a real narrow palate restricting the airflow. Or it could be some structure in the back of the throat, the tonsils, the uvula, adenoids, or it could even be a thick tongue falling back in the throat.
So let's say I've become aware that I have sleep apnea. My wife's poking at me to make sure I'm still alive.
You're right.
Right. And so can I just call you guys up at the sleep lab and say, I need a study done? How does that work?
Well, it's probably the best way to go about that. Here at this sleep lab, you can go to your family practitioner and tell them the problem you're having, and they're welcome to send a referral over directly to the sleep lab.
Okay.
And they'll be responsible for sending over the correct documentation, the H&P and all the information why you need to have a sleep study, and then also they'll get the authorization from the insurance.
Sure.
But, once that's in place, you can send that directly to the sleep lab, and we'll get you scheduled.
And so, okay, here I am, and I come in, and it's time for my study. Do I come in at night? Is that usually how it works?
That is correct. We operate 7 days a week. Oh. The patients come in sets of 2.
Okay.
Right now we have 4 beds, but we're looking for expansion because we're really growing.
Yeah.
And we'll soon hopefully have 6, maybe more beds. But right now the patients will come in at 7:30, 2 of them.
Yeah, 7:30 in the evening.
And then 8:30.
Okay.
Because it takes about 45 minutes to, get the patient oriented to the room and show them the treatment options and what they'll be doing.
Okay.
And we talk to them about how long the process is going to take and, get a little feedback from them, get them comfortable. And put all the electrodes on the patient. There's quite a few electrodes from head to toe. Yeah. Put a few on top of the head. That's an EEG. It monitors the brain waves. Then we put some on each corner of the eyes to pick up rapid eye movements. Right. So we're looking for a REM sleep. And then we put some on the chin and underneath the jaw to pick up the muscle clenching, what we call bruxism, if you have it grinding your teeth at night.
Right.
Also, we can look at the muscle tension. So when you go in the REM, it gets like pencil thin. Your muscles totally flatten out, so you don't act out your dreams. So we're looking for that.
Okay.
And then we put belts on the chest, the tummy for breathing, expansion of the abdomen and thoracic muscles, and then electrodes on the legs, and then probe on the finger for pulse oximetry, and let's see if I'm leaving anything out. ECG, heart rate.
Yeah.
If you can think of anything else, I'll be glad to put it on you.
Well, and this kind of highlights. So what I'm thinking is, if I come in and I'm not sleeping very well to begin with, and then of course I'm in a room I've never been in before, so I'm a little bit on edge.
Right.
And then I've got a lot of electrodes and sort of feeling like a test subject. Do you have people who just can't sleep at all when they come in?
That is very common. Yeah. Yes. Yeah. we try our best to, comfort the patient,
You serve warm milk.
Yeah, well, we got warm tea.
Yeah.
But
the decaf, I'm sure.
Yeah, and in some cases, I don't want to give anybody the wrong impression, but
Right.
in some cases, the doctor will prescribe a short-acting sedative.
Right.
Not very often, though. We discourage that, really, because if you do take a sleeping pill, it tends to make apnea worse. Mm-hmm. So if at all possible, if you have high anxiety, maybe, but we try and stay away from the sedatives. But most of the time, people will come in, they'll go right to sleep. But there are times, I kid you not, I do see patients that, they're not used to the environment.
Sure.
They're welcome to bring music, headphones, soft music. We have a fan that's kind of white noise.
Mm-hmm. That's my favorite.
Yeah. So unfortunately, it is a test procedure.
Yeah.
And I wish it was wireless, but there's really no way to do it that way. I wish there was.
So while all of this is going on in here with the patient, the door is closed, it's quiet, it's
Right.
a relaxing environment. And meanwhile, you're in the room next door and you've got these computer monitors there and you're monitoring all of this information.
That is correct. There's a technologist, a registered technologist at each station, and they monitor the patient all night long. They keep their eyes on that monitor, sort of monitoring all these parameters of all these electrodes, picking up all this electrical information and feeding it into the computer, and it comes across that monitor as a graph, just like the EKG. A lot of people have seen the ECG,
Sure.
It's the same thing with the brain waves, We got a whole lot more channels, probably about 16 in total,
Wow.
that we're looking at, not just the EKG, but a whole bunch of things.
Right.
Yeah.
And so you said earlier you've actually seen patients, maybe worst case scenario, you've seen patients stop breathing for 2 minutes. I mean, do you have to come
yes.
running in and or know what the acceptable bounds of
That
how?
is right. And these are patients that probably has been happening for a long time.
Right.
It's not a good thing. And if you look at their history, they usually have a history of heart problems, diabetes, the list goes on. And, you wish you could have treated them a whole lot earlier, or they would have caught this, then maybe they wouldn't have some of these conditions. Mm-hmm. But that's pretty much how it is here in the sleep lab. That's why they come, So most of our patients come from Kingman Pulmonary.
Okay.
Our medical director is Haven Malish, MD, and our past director is Robert Matheny, MD, both pulmonologists, and both boarded in sleep. But most of the patients coming from them usually have COPD or some kind of heart or lung disease. So, it's a little more critical.
Time for a quick break. We'll be back in just a moment for more with Mark Hopkins. Stick around. And welcome back to Focus on Your Health. I'm TG LaFredo, and this week my guest is Mark Hopkins. He's the clinical supervisor at KRMC's Sleep Disorder Center. It's the only fully accredited sleep disorder center in 50 miles of Kingman. So we've been talking about specifically sleep apnea, and I know not much about it, but I know the CPAP is generally the course of action for a lot of people who suffer from sleep apnea.
Yes, that is correct. It has been for a long time. The CPAP is the gold standard of treatment.
And what is it, essentially?
Okay, it stands for continuous positive air pressure. It's just a constant pressure of air. It doesn't blow you up like a balloon. Everybody thinks, oh, it's just going to force air into me. No, it does not. You put a little nose piece on. It creates a pressure, actually. And that pressure, when you go to sleep, is actually what's going to splint that airway open.
I see.
Okay, so then you can breathe normally. We also have BiPAP, bi-level pressures, 2 levels of pressure. Usually when we apply bi-level pressure, it helps you breathe in as well as breathe out. Normally, when we see that CPAP isn't really effective, we'll switch to bilevel. It's a lot easier to breathe with, and it helps the ventilation. So if you do have a lung disease, COPD, it helps blow that carbon dioxide off.
Gotcha.
It helps you breathe easier, and it improves your oxygenation. And then we also have one called ASV. I know it's getting a little technical here, but
that's all right.
That's adapt servoventilation. Some people have what they call central sleep apnea, which do not get confused with obstructive. Central is not obstructive. It's more brain related.
Interesting.
The message isn't getting down to the muscles of breathing. It's usually caused from congestive heart failure or brain trauma, somewhere the blood gases are not connecting with the heart and lungs, so everything shuts down. So we can switch over to what we call ASV. It's a little more sophisticated treatment machine that specializes and focuses on central activity and helps the patient stimulate that breathing.
A moment ago, we were talking about the patients coming in, and you touched on anxiety, and that made me think a bit about insomnia. Anxiety is one of my favorite causes for not getting enough sleep at night. And talk a little bit about. Go ahead.
Okay, I'll be real careful not to get into psychiatry here, but it's a real touchy subject.
I mean, that's a significant aspect of it, right?
It is, absolutely, yes. We are in the process right now of starting an insomnia program. There's so many patients out there that have insomnia. They just can't sleep. And, you know, I've been working on building this program for the last 6 months, and we're now just getting ready to launch it. And it's going to help people that have trouble sleeping. And what we find, insomnia, we're finding that there's a lot of precipitating factors that really, which is causing which,
right,
you know.
Right.
Is it true insomnia? If it's true insomnia, it probably is a cognitive or behavior or brain-related,
right,
your thought process that's keeping you awake. Some of those may actually need to go to a mental health specialist.
Right.
However, what we also find is a majority of them do have precipitating factors such as obstructive sleep apnea, restless leg syndrome. That's another one. It's where you jerk your legs all night long. It
consciously, or you can't hold still, or
that's right. Your legs. Well, there's periodic leg movement syndrome. That's where your legs jerk every 20 seconds throughout the night.
Yeah.
And then your restless leg syndromes usually occur at the beginning of the night.
Okay.
They prevent you from going to sleep. That can be controlled with medication.
Okay.
Once we get those under control, normally the insomnia just tends to go away.
You really find that for patients who aren't as familiar with, there's so much to know, right?
Right.
And so for patients who just aren't sleeping well, they say maybe insomnia is like a catch-all term, like, oh, I just have insomnia lately.
That is correct.
And then on a closer examination, you find
insomnia is a term used very loosely.
Right.
And that's pretty typical. It's pretty common, you know, when you don't feel like you're sleeping or having trouble going to sleep, then you just automatically say, hey, it's insomnia.
But for you, in a clinical setting, insomnia means something more specific.
No, it could be multi-directional.
Oh, okay.
Yeah, it could mean a lot of things.
Yeah.
So it could mean 4 cats and 2 dogs in bed with you, you know.
So you have to do kind of a social history and talk about the background here.
Absolutely.
Right?
You got to look at all aspects of their life,
'Cause
from the bedroom to what they're thinking in the daytime to, you know, what's going on with the patient.
Right.
Yeah. It could be actually their thought process. It could actually be thinking what's about staying awake all night.
Yeah.
And so there's a whole lot of different things, you know.
I think about that, like when you're watching baseball, for example, right?
Uh-huh.
And the shortstop makes an error. And then like the ball is coming back to him. He's going to have to make another play right after that.
Right.
Because it's in your head. And I think, you know, when you have a bout of insomnia, whatever that means,
right,
you start, oh, God, no, now it's 9 o'clock. Now it's 10 o'clock. I have to go up to bed soon.
Those are clock watchers.
Yeah.
Yeah. People actually look at their watch all night long.
Yeah.
So when that happens here in the lab, I say, where do you have to be? Right. You know, because that's called clock watching. That can actually keep you awake all night.
Yeah.
It can be simple little behaviors like that, you know, that keep you awake. keeping a clock in your bedroom that's a bright light. Bright is a very high stimulator for keeping you awake.
Or the ticking, maybe.
That's right. And then also the TV. Some people sleep with that TV on all night. TV actually is used for one thing mostly, and that's
a sedative.
To entertain. So you entertain yourself. It's really, you could be sleeping quite well, and then all of a sudden a commercial comes on, and it just, that brain response, that part of the brain that doesn't go to sleep will pick up on that. And you just don't quite go into the deeper sleep like you should.
Okay.
So a lot of people don't see this because they are asleep, for one, but they don't see the stages of sleep.
We were just talking, I did an interview with my wife, who's a pediatrician, and we were just talking about sleep in young people and their tendency. More and more she hears about patients who, take their cell phones to bed, and it's there on the bedside table, and it's blowing up, as they say, all night long. It's going off, and
that's one of those. We have what we're looking for too is what we call sleep hygiene, and sleep hygiene more has to do with behaviors. Staying up all night. And typically with teenagers, we call what we call phase delay syndrome. They just don't want to get up Monday morning because they stayed up till 4 a.m. on, Saturday and Sunday. So, it creates a habit, and it messes up your circadian rhythm. That's another thing we try and reset the circadian rhythms. That's your biological time clock, to get everything back in balance. So I know it's getting a little more technical, but a lot of these sleep hygiene factors can really interfere with sleep, and that's one of them. The TV and the cell phones and the clock watching, and a lot of it's simple things that can be fixed.
Yeah.
It could be what you eat too, and when you eat, and when you exercise. You should not exercise right before bed. And be careful what you eat.
Downing a bunch of Smarties or...
yeah. So anyway, there's a lot of factors to look at.
And caffeine intake, all of that, right?
Right. Caffeine definitely. Even smoking is a stimulant.
Right.
So, and no alcohol before bed, because that absolutely, if you have apnea, it'll make it worse.
We talked about some of the common disorders that you see: apnea, insomnia, restless leg syndrome we touched on. Can you talk a little bit about narcolepsy?
Narcolepsy. Okay, that's inability to stay awake, falling asleep inappropriately. It's just like you and I. It'd be very embarrassing right now, of course, if you just fell asleep. But
it is public radio.
Well, so. It is. It does happen. And in fact, a doctor I worked for up in Seattle, he had narcolepsy. And I'll tell you the story.
Was he a sleep doctor?
He is.
Yeah, no kidding.
Yes. And he doesn't mind telling the story, but I won't mention his name for that. But anyway, he had narcolepsy. He has been treated, by the way, you can be treated with narcolepsy with medication. But he was seeing a patient with narcolepsy. The nurse came out and said, "Man, they've been in there for a long time."
Oh, no.
She opened the door and they were both asleep.
Oh, my gosh.
Yeah, so it happens.
And that's a funny story, but I mean, you could be stopped at a red light.
Oh, absolutely.
Okay.
Yeah.
So then it's pretty serious.
Right. And there's several things that, we do what we call an MSLT. It's a multiple sleep latency test in the daytime. We do daytime studies for specifically for narcolepsy, testing for that. These are nap studies that are done throughout the day. And those nap studies will tell us generally if the patient has narcolepsy or not.
Okay.
We also, not to get off the subject here, but we also do daytime study for shift workers as well.
And so you just brought me to where I was headed, which is there's a subtext going on here because you guys have to stay up all night studying the patients who aren't sleeping. And so you make this sacrifice. The people who work in this lab sleep weird hours.
I'm glad you mentioned that because we could be our own best patient.
Yeah.
My techs, they stay up all night. And the thing is, even after years, you still don't totally get used to that. I mean, you adapt to it, but your body automatically, uncontrollably, your body temperature shuts down about 3 and 4 o'clock in the morning.
Yeah.
And that's usually when you get your best sleep. Well, what's happening with them is they're working during that time. And they're trying their best, drinking lots and lots of coffee to stay awake.
And stay
and
warm.
They don't sleep well because they got all this coffee in them. They don't go to bed till about 11 o'clock or noon.
Right.
And,
They've got blankets over the windows at home.
That's right.
I did a little bit of that third shift work myself.
So it's really a tough deal, but we do shift workers in the daytime here for studying too. I've had several nurses here at the hospital and doctors and people that even the corporations around town that the managers and stuff that work overnight.
If you are a third shift worker, are you just resigned to a life of less rest, or can you balance it out to where you just flip-flop day and night?
I guess that really depends on the individual.
Yeah.
I've talked to people that it just never works.
Yeah.
And then I've talked to people that says no problem. So I think it really has to do with each individual.
Mark, this was the fastest radio show I've had in a long time. It's such interesting subject matter. I hope you'll come back, or I hope I'll come back and we can do this again sometime.
Awesome. Yeah, I enjoy this. It's fun. It's a very interesting field to get into.
Yeah.
I just want Kingman to know that we diagnose and treat so many different disorders. We need to reach out to so many different people, and I think this insomnia program we got undergoing will be great. I also have another program I plan on working on, and that has to do with a sleep advocate program with patients in the hospital. Because you'd be surprised, about 80% of the patients don't even know they got sleep apnea.
Yeah.
And the reason we catch it is not always their spouse, but when they have to go to the hospital.
One of the
so
nurses.
I'm going to start a program where I go over and see the patients in the hospital. I think it's a great start for reaching out to the patients,
So more projects for you to work on instead of sleeping.
Absolutely. We're going to keep hammering at it until we get everybody fixed. So.
That's Mark Hopkins. He's the clinical supervisor for the KRMC Sleep Disorder Center. Mark, thanks so much.
You're quite welcome. Enjoyed having you.
And that's the program. I'm TG LaFredo. Thanks so much for listening. If you'd like to write to me, you can send me an email at foyhradio@gmail.com. That's Focus on Your Health, foyhradio@gmail.com. We'll catch you next time.